It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preecish Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
This is a 39-year-old female with newly diagnosed stage 3b MSI stable rectosigmoid adenocarcinoma. I believe it's more rectal, if I'm correct, with suspected involvement of the anterior mesiorectal fascia on pelvic MRI. She presented with rectal bleeding and alternating diarrhea and constipation for several months, and her ECOG performance status is 0. Medical history is non-contributory, the social history is non-contributory, and the family history is only significant in regards to maternal grandmother who had colon cancer in her 70s. So a little bit older than the average age patient in the United States. In February of this year, she had a colonoscopy with a partially obstructing tumor consistent with a moderately differentiated adenocarcinoma, MSI stable. Her CEA is 9. Her CT scan of the chest, abdomen, and pelvis reportedly demonstrates no evidence of distant metastatic disease. Dr. Siegel, do you care to comment about this imaging?
Sure. On the bottom image, we have a post-contrast dynamic CT through the pelvis. And the top image is the high B value diffusion imaging, which I alluded to earlier. Now, if you look at the bottom image below the uterus or behind the uterus, there's a mass associated with the rectum with a breach of the serosa at about the 1 to the 3 o'clock position. There's also multiple small nodes in that region. The criteria that we use for abnormal nodes are any nodes greater than 9 millimeters are considered positive. Nodes that are between 5 and 9 millimeters have to meet 2 of the 3 criteria of an indistinct margin, a heterogeneous internal architecture, or round. And lymph nodes less than 5 millimeters have to have all 3 of those criteria. Every once in a while, we'll see a whole group of lymph nodes coalesce together that don't exactly meet the criteria. And usually what we'll do is we'll mention it in our dictation that these don't meet criteria, but that they should be examined on follow-up exam. And we're sort of alerting people to keep an eye on it.
Thank you. So I just want to highlight, this is a 39-year-old female, and the average age patient is 67 in the United States. And so given that it is Colorectal Cancer Awareness Month, I think we do want to make sure that people understand that patients can present with symptoms that are suggestive of colorectal carcinoma at a much younger age than expected. And these are some of the symptoms that they present with, and that should guide people to get screened with a new screening age of 45. So I would love to get the input of our multidisciplinary team regarding this patient. So starting with Dr. Kubi.
Yeah, thank you, Dr. Ng. You know, I think the first thing to sort out with this particular patient is how bad her symptoms are before getting on board with neoadjuvant therapy to see whether a role for pre-therapy diversion would be necessary. If the patient can be on a liquid diet and started on therapy, then her symptoms may actually resolve without requiring diversion. But that's one of those scenarios where you actually have to meet the patient and really take a very good history.
Dr. Benson?
So certainly this is exactly a case that needs an expert multidisciplinary team review before any intervention is undertaken. Your point about young people, Dr. Ang, is critical with the rising incidence of colorectal cancer, particularly rectal cancer in our younger population of patients, means that we really have to take any suspicious symptom in a younger person seriously. Even if this patient has a microsatellite stable tumor, we generally recommend genetic counseling because of her age, and it does affect screening recommendations, for example, the patient's brothers and sisters, parents, and so forth. This field of neoadjuvant therapy is certainly rapidly evolving, and we're moving more and more to the concept of giving total neoadjuvant therapy. It's also interesting where we're looking at the location of the tumor. So if I read this correctly, this tumor was at least 10 centimeters from the anal verge. And the recently accrued prospect study in the cooperative group system was looking at patients with more proximal tumors. And there's a question, for example, is neoadjuvant chemotherapy sufficient for these individuals? I think still many people are considering either a sequence of chemotherapy followed by radiation or radiation followed by chemotherapy. And we're also looking for patients with complete response who may not go to surgery. So there's, in fact, Dr. Patel, I'm sure, will comment on short course versus long course radiation. But nonetheless, in a multidisciplinary team review, this would be the discussion about what sequence, what strategy of chemotherapy, chemoradiation for the individual should be taken prior to surgery.
Thank you so much. Now, Dr. Patel, can you comment on the sequencing? You would prefer the chemoradiation therapy first, followed by systemic, or just the reverse in this case? And then as Dr. Benson mentioned, how do you decide which patients you prefer for short course given the repeater data versus long course? And then I'm going to ask Dr. Kubi about, this is a young patient, what about that watch and wait concept? So let's go to Dr. Patel first.
Yeah, no, thank you. I can't emphasize enough, I think, that the issue of younger and younger age with diagnosis of colorectal cancer. Something that comes up that hasn't come up a lot for me as a radiation oncologist with younger patients is fertility. So with this young female patient, I think that's something, we'd want to have that discussion. And it's challenging, of course, because if there is a desire for fertility preservation or egg harvest, we've got to move quickly. We've got to have a multidisciplinary team that understands, the sort of that we're under the gun. And so that's been a challenge in cases where we've desired fertility preservation or egg harvest. And in those cases, the ovaries change dramatically, and that, of course, might influence the decision of the timing and the sequence of the therapy, as you've mentioned. So that's something that sometimes now comes up that didn't in the past. So this is a fascinating area now with a lot of new data to help guide us. I would say with a threatened circumferential resection margin, that often at our institution it means that we're going to include radiation in the neoadjuvant therapy at some point. And I totally agree, Dr. Benson, that for the vast majority of patients now, we are doing total neoadjuvant therapy with all the systemic therapy and the chemoradiation up front. The German AIO-12 study was a study that compared really giving the chemoradiation first or giving the chemoradiation after the neoadjuvant chemotherapy. And we seem to see that if you give the radiation first, and then the effect of that really is to delay the time to surgery, we tend to get better pathologic response. And so we've seen that in the German study, and then in the study that you just mentioned, Dr. Rang, the Rapido trial, a similar finding in that short course radiation was given followed by systemic therapy, and that was compared to a standard chemoradiation and then right into surgery. And so my takeaway there is that delay to getting to surgery is really what's giving us time to see the better responses. And so at our institution, when we really are pushing for the optimal response in the tumor, for instance, if not in this case, but another case for a distal tumor where you're worried about maybe the need for APR, that tends to drive the decision to give the radiation first. In cases where we're much more worried about, for example, significant nodal disease and the risk of micrometastatic disease, in that case, we may choose to do the chemotherapy first. And also in the upper tumors, as Dr. Benson mentioned, there's the possibility that maybe a remarkable response could lead you to then choose not to do radiation, and that may be attractive in a young patient as well. So you know, a lot of considerations. In general, with a threatened circumferential resection margin, like in this case, I would prefer a maximal response, and that typically means chemoradiation first. And to touch on the short course versus long course debate, I think at this point, we've got ample evidence that short course radiation is safe, is effective, and really could be used in any case where you might consider long course radiation. So, you know, it tends to be institutional. At our institution, we're more often doing long course. Dr. Siegel's institution, I think, is almost exclusively doing short course. And I think both are totally standard options at this point. And so whatever the team, the multidisciplinary team is most comfortable with would be the best approach.
Thank you so much. Dr. Kubi, I'd love to get your input about the time frame for surgical resection following completion of TNT approach, presuming the patient received long course, and then also get your viewpoint on your thoughts. You know, we're seeing more young patients now with rectal carcinoma. How are you looking at watch and wait at your institution as a new approach?
Yeah, so this is something we discuss frequently in our tumor board, you know, with Dr. Patel. And in terms of timing of a surgical intervention, you know, probably no sooner than 6 weeks after a completion of radiation therapy. Sort of that 6 to 12 week range has been the ideal sort of time period, but even waiting a little longer is probably thought not to be detrimental to these patients. Now, the discussion about a watch and wait approach, this was originally sort of described or proposed in the early 2000s by Dr. Habogama. And I think the initial trial showed only a 5% or less than 5% local recurrence rate with just total neoadjuvant therapy and no surgery. And if you follow these patients and they do recur, then coming back and doing salvage therapy is thought to provide sort of the same survival as if you had done the initial resection. Now, several studies have been performed that have not replicated those data exactly, and there are prospective trials that are actually underway. But if this patient had that type of great response, then they would be potentially a candidate to be put in a watch and wait approach.
Thank you so much. It's a great discussion. So now we're going to change the scenario a bit. This is a 52-year-old female who presents to the emergency room with a T3b N1 tumor. She has multiple symptoms. She's MSI stable, and unfortunately does not tell me the location of the tumor, but I believe we have some imaging. So Dr. Siegel, can you please comment?
Sure. So we have high resolution T2 weighted images, a sagittal on the left, and the image on the right, it's not really a coronal and it's not really an axial. It's sort of angled through the internal sphincter. And I don't have a pointer, but if you look at the image on the left, you can see a lobular tumor involving the distal rectum. And how we measure is, again, I can't put my pointer, but we find the anal rectal angle, and then we measure up 5 centimeters, and that's what we define as the distal rectum. The next 5 centimeters is the mid rectum, and the next 5 centimeters up after that is the upper rectum. There's this lobular mass, and when you look at it on sort of the angled coronal views, you can see that there's involvement of the internal sphincter, probably extending from about maybe 9 o'clock up till 12 o'clock. That's sort of a lobular mass that's indistinguishable with the internal sphincter. One of the reasons why we like to sort of carefully measure whether we're dealing with low, mid, or high rectal tumors is tumors that extend high out or higher out of the rectum and involve the sigmoid sometimes behave differently and behave more like sigmoid colon cancers and have a higher incidence of liver metastases and have other slightly different imaging features. So we try to categorize it into the where in the rectum it belongs the best.
Thank you. So Dr. Patel, we've got a young, older than the last patient, but still young, in early 50s. Now what appears to be a low-lying rectal tumor. So I would love to get the input here, where you think the sequencing would lie. This patient had multiple symptoms. I don't know what the symptoms are, so I'm presuming that they're having some bowel motility, but maybe some tenesmus, maybe some bleeding. I'm presuming the H&H is stable. How would you look at this patient that's just opposite in regards to distance from the anal verge?
Yeah, so this is sort of what I was alluding to before. So with this type of a distal tumor location, evaluation with colorectal surgery, of course, is critical. But you worry now more about the risk of a definitive surgery that's going to lead the patient to permanent colostomy. And of course, downstaging is one of the major benefits of any neoadjuvant therapy in rectal cancer. So anything that leads to a maximal response in this case, which hopefully would translate into a better chance for organ preservation, is really, I think, what our preference would be at my institution. So in a case like this, even for T3 N0 disease, we're starting with chemoradiation first, followed by systemic therapy, again, to try to give ourselves the best chance, either for an LAR or, again, in some cases now, non-operative management.
Dr. Kubi, do you care to comment on this early 50s low-lying rectal tumor?
Yeah, no, I think the scenario is pretty similar, but in this case, yeah, the definitive operation would unless there was great downstaging, could be an abdominal perineal resection with a permanent colostomy. So the stakes are even higher in this case. And if we can get to a great response to therapy with a complete histologic response, radiologic and physical exam response, then this would be the ideal patient to put in a watch and wait and frequent surveillance program.
Thank you. And then Dr. Benson, in regards to total neoadjuvant therapy, do you have a preference of FOLFOX in that setting or CAPOX?
We use both. So if we're giving long course radiation, and in this case, I think we would favor beginning with radiation. If we gave long course, we would give capecitabine Monday through Friday during the course of radiation. With short course, of course, we don't give chemotherapy. But in terms of the post-chemo radiation or post-short course component of total neoadjuvant therapy, I give patients a choice of FOLFOX or CAPOX. I think in this setting, they're both appropriate to consider, and whatever works best for the individual patient.
I fully agree. I do the same.